STEMI, unstable angina, stable angina, everything in the video lectures. But then there you study it, as I told you yesterday, fragmented. So you know that, okay, this topic is about acute coronary syndrome. If I study, I can write a 10 marks on acute coronary syndrome. But when you step into the clinics and you start the patient begins with chest pain. When he says, I have got chest pain, acute coronary syndrome is only one of the differential diagnoses. There are n number of causes for someone presenting with chest pain. So today we'll learn how we navigate from patient presenting with just one complaint at chest pain to finally go to the diagnosis of STEMI. And for that matter, we will also learn how we rule out other differentials or how we rule in STEMI. Okay. So how these patients are going to present? These patients are going to present with acute onset chest pain. Now, before we discuss how we approach the case, let's imagine that you are in the emergency room. You have just finished your final prof exam and you are now a fresh intern. And on the day one of your duty, there is one patient in the emergency room who is complaining of chest pain. The staff nurse first speaks to the patient and then comes to the intern saying that, sir, there's a patient with chest pain. Please go have a look. So you walk up to the patient and ask him, what's your problem? Or what brings you here? Guys, remember this question, what brings you here, is a very safe question to pose to a patient so that patient opens up and starts telling about his complaints. Never walk to a patient and ask, do you have chest pain because my staff nurse told. Let him open up his story. So walk up to the patient and ask, what brings you here? Or how come you had to come to the hospital? And he opens up and start telling the complaints. Let's imagine that he said, sir, I'm having chest pain from past 20 minutes, 30 minutes, or whatever. It is an acute onset chest pain, not a chest pain going on for months or years. Okay, so we have an acute onset chest pain. At this moment itself, in your mind, you should have some possible differential diagnosis. So how actually we take a symptom to diagnosis is, at each stage, when I just hear about the symptom, I make a list of possibilities in my mind. And then as I collect the history helps me to rule out some of the differential diagnosis. For example, let's say when he complained of chest pain, I might have had 10 possible DDs. Okay, complaint chest pain, there are n number of causes. Let's say I am thinking about 10 possibilities. As I go through the history helps me to eliminate some of these possibilities, and then at the end of history I may be left with 7 differential diagnoses. Then I go through the examination might help me to rule out some more possibilities. So at the end of examination, I might be left with only 3 differential diagnoses. And then we subject the patients for investigation to rule in or rule out the remaining possibilities. And then we finally come out with one confirmed diagnosis. So this is how the process of diagnosing the patient goes on. And you know what? The maximum elimination occurs at the level of history and examination. Investigation merely helps you to confirm in most cases. That's why we should be learning how to take history, what questions to ask, how to examine, and how to navigate through this information to narrow down our differential diagnosis. Okay, so now we have imagined that we have a patient with chest pain. So let's think about the possible causes for acute onset chest pain. Now again, any complaint that patient talks about, first thing you have to think of is the worst case scenario. Like if someone is complaining of chest pain, there are simple causes for chest pain like migraine, tension type of headache, cluster headache, paroxysmal hemicrania. But we should also think about more dangerous forms. What are more dangerous forms? Intracranial hemorrhage, a tumor in the brain abscess, meningitis. We should always prioritize ruling out the more dangerous forms of or dangerous causes for this particular symptom. So when we're talking about chest pain, what is the most feared cause for chest pain? It is the ischemic heart disease or angina, and common words MI, right? So angina is one of the possible causes. What is angina then? Angina is a chest pain due to myocardial ischemia. Due to myocardial ischemia. So there is an entire spectrum of causes for angina. The important ones we need to remember is there is something called as stable angina. And then we have unstable angina. We also have NSTEMI and STEMI. So among all these possible causes for angina, the most severe form of disease is STEMI. So this is an entire spectrum of ischemic heart disease. On the milder end of it, you have stable angina, and on the severe end of it, you have ST elevation MI. So this is one of my differential diagnosis. Okay. Apart from that, chest pain can also occur because of esophageal disorders. For example, I'm just giving you a few examples. Patients can have chest pain even in gastroesophageal reflux disease. Patients can have also chest pain if they have diffuse esophageal spasm. Diffuse esophageal spasm, where you get this classical corkscrew esophagus multiple segments constrict simultaneously, giving you corkscrew esophagus, and that gives bad pain. Okay, then you can also have the pain because of what you call as Boerhaave syndrome or esophageal perforation. Esophageal perforation. You can also have malarious tear. Malarious tear, where there is superficial tear in the esophageal mucosa because of severe retching or vomiting. So these are esophageal disorders. They can also cause chest pain. Okay, and then third is costochondritis, inflammation of the rib and their cartilage junction, the costochondral junction. There can be inflammation, often caused by viral infections, and that can also cause chest pain. And inflammation of the pericardium, which is either idiopathic, that's the most common scenario, or it can also be because of viruses or other causes. So whether it is viral, because of aortic, of common causes for acute onset chest pain. Now my patient who is complaining of chest pain may be going through any of these. He may be going through MI, he may be going through unstable angina, he may be going through stable angina, he may be actually having an esophageal disorder, he may be having acute pericarditis, he may be. Now my job is to figure out which one is the most likely explanation for his symptoms. So for that I need to take history. So at this point of time I have made 6 important differential diagnoses. Now I ask him more questions so that I can either rule out some of these differentials or rule in some of them with more confidence. So for that, of course, I look at the duration, right? So of course, we're talking about acute, so patient may be complaining of minutes to hours and not days or weeks or months. After that, we look at the location of the pain, an extremely useful tool to rule in or rule out some of the differentials. For example, if I have angina, what is the location of the pain? If I have angina or ischemia of the heart, the pain is located in the dead in the center of the chest. You can either call it as central or retrosternal or retrosternal. So if it is central or retrosternal, it is highly suggestive of either it is anginal pain, or you can also have acute pericarditis pain, which is central or retrosternal. On the other hand, it can be lateralized to one side. Means patient is not complaining of pain which is in the center, it's more towards the side. So if it is lateralized, it is less likely to be the anginal pain or pain of acute pericarditis, but it could be something else. The esophageal disorders also can present with retrosternal chest pain. So diffuse esophageal spasm or GERD may also have retrosternal chest pain. Lateralized, one possibility is it could be pleuritis. If I have inflammation of the pleurae, the chest pain may not be at the center, it may be lateralized. So if the patient is saying, sir, pain is not in the center, it is somewhere on the left or somewhere on the right, it is less likely to be angina, less likely to be acute pericarditis, less likely to be esophageal disorders, more likely to be localized causes like pleuritis. So we will certainly look at the location of the pain. And then second thing I want to know is, what are the aggravating and relieving factors? Extremely useful tool to rule out or rule in some of the differentials. For example, if it is ischemic pain or angina, what aggravates angina? The angina is where myocardium is not getting as much blood as it wants. Anything that either decreases the blood supply or increases the myocardial oxygen demand will worsen anginal pain. So basically, let us say like an X amount of blood is required by the myocardium, but we are not able to give that much blood. So I'm experiencing ischemia. Now, Either I can decrease the supply or increase the demand, right? X becomes 2x, 3x. Either myocardial oxygen demand increases or coronary supply decreases, then angina will worsen. How can I increase the myocardial oxygen demand? By asking the patient to do more physical activities. If I start doing physical activities, heart needs to do more work to deliver more blood to the working muscles. Myocardial oxygen demand increases. So pain of angina generally tend to get aggravated by rest. So if it is angina, then generally you will see aggravated by exertion, and it often gets relieved by rest. Or also I can increase the supply of the coronaries by giving a vasodilator. Coronaries are blocked for some reason, that's why you have ischemia. I give a vasodilator, coronaries get dilated, so blood flow increases. So if blood flow increases, angina can come down. If it is due to ischemia, if pain is due to ischemia, it can come down. So it is relieved by rest or taking nitrates. Okay, but patient says, sir, physical activities have no bearing on my chest pain. Whether I'm exerting or I'm just sitting quiet, it is there. If I take nitrate, it's not getting relieved. So either you have a more aggressive form of ischemic heart disease or maybe some other differential diagnosis. Okay. Now, is the ischemic pain having any relationship with the posture? Like if I'm sitting, leaning forward, standing, bending, does the pain change? No. The ischemic pain or anginal pain does not change with respect to posture. But if I have acute pericarditis, the pain of acute pericarditis, in acute pericarditis, this is your heart. Heart is surrounded by two layers of pericardium. One is visceral, which is adherent to the myocardium, and the other one is parietal, separated by it. When there is pericarditis, both layers become inflamed, and when inflamed layers rub against each other, the pain becomes worsened. And this rubbing can be accentuated or increased by inspiration, because around the heart you have the lungs, and during inspiration lungs expand. So as the lungs expand towards the pericardium, they can squish the pericardium. Two layers can come much more closer and rub against each other much more harder, and pain can worsen. If the patient says, sir, my pain is getting worsened by inspiration, then it is a pointer towards acute pericarditis. In acute pericarditis, the pain is aggravated by inspiration and lying down, and it gets relieved by expiration. They feel better during expiration and on sitting and leaning forward. So patient of MI will not find any relief whether he is sitting or lying down. The pain will persist. But while acute pericarditis patient, if he lies down and when he takes deep breath, it hurts them more. So their comfortable position is they want to sit and lean forward, and they hesitate to take deep breaths, because every time they take a deep breath, the lungs expand and they push the inflamed layers of pericardium together, and it worsens the pain, right? So that's the second point that helps you to differentiate. Okay, then the third point, apart from the location, duration, another point we need to pay attention to is the nature of the pain. Nature of pain. So let me tell you a story. You should tell me which one do you think is actually a case of MI. So we had two patients. Let's say one is labeled as A and the other one is labeled as B. Okay, both of them have chest pain. Patient A has severe retrosternal chest pain, means it is centralized, it's not lateralized, it's dead in the center. Severe retrosternal pain, which is extremely severe. He says that this pain feels like someone is repeatedly stabbing me. Stabbing or penetrating quality of pain. Penetrating or stabbing quality of pain. And I have another patient in the same emergency room who is also complaining of chest pain. He's also having acute chest pain, but his pain, he says, sir, it is not very bad. It feels like something is constricting inside my chest, or it is squeezing type of pain. Whom do you think is actually a case of MI? Is it the one who is complaining of penetrating type of pain, or is it the one who is complaining of squeezing type of pain? Whom do you think is a case of MI? You're not getting the voice. Are you sure you're not getting the voice? Can you drop a text to me so that I get to know whether you're able to hear right now or not? Because we have a little new voice setup and a new mic setup, because yesterday there were a lot of audio issues. So just let me know if you're able to hear or not. If there are issues, I'll get it fixed. Okay. Okay, fair. So what do you think is a case of MI? The one with the penetrating chest pain or the one with the squeezing chest pain is a case of MI? Who is a case of MI? Now, I feel most of you would answer the person with severe stabbing or penetrating kind of chest pain as a case of MI. And this is less likely to be a case of MI. This is an answer I get every time I ask medical students to pick up one. Why that happens? Because we have been conditioned to believe that a chest pain of MI is very severe, penetrating, or stabbing. Who conditioned us to believe so? It's not your medical educators, it's not your college teachers, it's not your patients, but it's the entertainment industry or TV, movies, serials. Because as a child, I started watching the TV, and when I started watching the TV, my first encounter with MI was on TV, not in my medical college. So in the TV, the typical story goes like this. There's an elderly man who is the father of the heroine, and the heroine walks up to him and says, Dad, I am in love. I think I'm in love with this particular person called X. But the only issue is he does not belong to our community, our religion, our caste, or something like that, or not our socioeconomic status. And that shakes the cultural values of the father. He immediately develops an MI. He holds the chest and he gives a facial expression which is very grimacing. He's like, oh, extremely grimacing facial expression. He collapses, and then to complicate the scene, he has one small bottle of medications which if he takes, his problem gets sorted. But unfortunately on that day, either the bottle falls down and rolls away and it goes beyond the reach, the heroine runs to get it, or she gets it and when she opens it, there is no pill in it, and then he dies. This is a scene that we have witnessed in many movies, and that has made us to believe that the patients of MI present with severe retrosternal chest pain, which is sharp or penetrating in nature. But the truth is, most of your MI patients are going to present with squeezing pain rather than penetrating pain. You might have heard about the singer KK. Absolutely, I loved his voice. So he was doing a concert, I guess, in West Bengal, Kolkata, or somewhere, where he did experience some kind of chest discomfort. But of course, none of us think just discomfort is MI, rather severe penetrating pain is MI. That's the notion. So he ignored his symptom. He finishes the concert, goes to the hotel, and then dies. So many similar stories. Even in the medical colleges, patients come to the emergency room, some kind of chest discomfort. The first instinctive diagnosis made by many interns is that he is having gastritis or reflux disease. They give a pantoprazole, send him home. Sometimes patient comes back later with worsening condition, or sometimes they are even brought dead. We need to pay attention to finer details when we study about symptoms. This penetrating pain is more likely to be acute pericarditis or esophageal rupture, that is Boerhaave syndrome, or Mallory-Weiss tear, or even aortic rupture. And this squeezing pain is more likely to be the pain of ischemia, or what you call as angina. So this is a very, very important point. There are a lot of things that we need to unlearn going forward. Okay. So nature of pain is an extremely important thing. So if it is penetrating or stabbing, then it is more likely to be pain because of what are the conditions I can think of? I can think of pericarditis. The pain of pericarditis is sharp, penetrating, and stabbing. It could be Boerhaave syndrome. Boerhaave syndrome. It could be dissection of aorta. So when I put this information that patient has a squeezing type of pain, then I know it is more likely to be MI. But if he says sharp penetrating pain, it is less likely to be MI, more likely to be the other causes that we are discussing here. So definitely I need to ask about the nature of the pain. The nature of the pain is squeezing type. In case of angina, anginal pain is squeezing. You can do one simple thing, ask the patient to show where is the location of the pain. In case of the Borev syndrome or rejection of aorta or pericarditis, most of the times patient literally pinpoint to the sternum saying that somewhere here. But if you ask the same question to a patient going through angina, the pain is a little more diffuse. It's not sharply localized. So they can't pinpoint and say, it is here. They will generally show like this. This is where we have this pain, somewhere addressing towards the center of the chest. Many times patients going through angina, in the books at least it is described that they hold a clenched fist against the chest, the site where they have the pain, that is sternum. Over the sternum, they hold a clenched fist. And we had given a name for this. The name is called as Levine sign. Patients with angina holding the clenched fist on the chest. I have not observed this very often in our emergency rooms. In our emergency rooms, because there is a Indian body language. Whenever we have pain, somehow we are conditioned to believe that rubbing our palm over the site where there is pain gives us comfort. If you have abdominal pain, patients will be doing this. If they have chest pain, they will be doing this. So I have seen a lot of patients coming to the emergency room with the palm rubbing on the chest. Holding the clenched fist on the chest, I have not seen very often, but in the books it is described and they call it as Levine sign. So what are the information I am looking at now? Yes, I am looking at duration, and right now we are talking about acute pain. So all the patients who are having acute pain are our differential diagnosis. Then we look at the location. If it is central or retrosternal, we think about angina, esophageal disorders or pericardial disorders. If it is lateralized, it is more likely to be pleuritic or other localized causes. Then we look at aggravating and relieving factors. The anginal pain generally gets aggravated by exertion and relieved by taking rest or nitrates, while acute pericarditis pain gets aggravated by inspiration and gets relieved by expiration or sitting and leaning forward, aggravated by lying down and relieved by sitting and leaning forward, because the position and expiration decreases the chance of 2 layers of pericardium rubbing. That's why it gives the relief. Then we will look at the nature of the pain. After the nature of the pain, there are a few more things that we need to take into account. The conductance or radiation or reference of the pain. Conduction or radiation or referral of the pain. Where is the pain getting referred to? Now, for example, if I have angina, where is the pain referred? One of the common pattern I have observed among the interns and medical students is once they have an emergency room call saying that there is a patient with chest pain, first thing I see them asking is, does the pain go to the left upper limb? The patient says, yes, sir. Then they're like, this is a case of MI. I made a diagnosis. Sister will do the ECG and then sort it. The moment patient says, no, sir, I've seen a lot of them just returning back from the patient saying that, okay, this is not an emergency because the pain is not getting referred or radiated to the left upper extremity. So acute coronary syndromes, the MIs are kind of ruled out. It may be now GERD, peptic ulcer disease or something simple. So I will approach this case casually. A big fatal mistake. Remember, yes, the anginal pain can be referred to left shoulders and left upper limb. I said can be, but it can also be referred to various other locations. So anginal pain can be referred to shoulders, though most commonly left shoulder. It can be referred to even right shoulder. So I will write it as shoulders. It can also be referred to jaw. It can also be referred to the tip of the tongue. It can also be referred to neck. It can also be referred to epigastrium. It can rarely be referred to back. So literally the pain of myocardial infarction can be referred anywhere and it can mimic as various disorders. And that's why we have seen patients being given pantoprazole and sent home because the patient was complaining of epigastric discomfort rather than frank chest pain, because the pain was referred to epigastrium. We have also seen patients landing up in dental clinics with the jaw pain or tooth pain because the pain can be referred to jaw and tongue. Many times dentists have even done interventions thinking that, because see, Most of the patients of MI will be past middle age, 40s, 50s, or 60s. Though we have started seeing cases in 30s, most cases are past 40s. Some caries tooth will invariably be there in most individuals. So when such patients develop MI and the pain gets referred to jaw, they may land up in dental clinic, and when dentist examines, he or she will also find some caries tooth. So they might think that is the cause for the pain, and they might even intervene, tooth extraction, root canal. And when patient's condition deteriorates, then they sense that okay, something is wrong, and then patients might land up in the medicine OPD or the medicine emergency rooms. So it's important that all of us be aware that pain of MI can mimic various other disorders because it can be referred anywhere. Don't do this mistake of believing that if it is referred to left shoulder, then only it is angina. Most commonly it is referred to left shoulder, but it can be referred anywhere else also. Then in case of acute pericarditis, the pain is often referred to the back. In acute pericarditis, pain is often referred to back. So where is it referred to also holds some value in differentiation of disorders. More than differentiation of disorders, it just makes us aware that the MI can mimic as various disorders, and we should be cautious. And anyone complaining of epigastric pain, tongue pain, jaw pain, it could be the sign of ischemia as well. Okay, so when I gather all this information from the patient, you see one pattern emerging, and then we will see which pattern it fits into so that we can have our differential diagnosis narrowed down. Now we have got the complaint, we have got the history, and from the history and the complaint, now we will try to narrow down what are the differential diagnoses that I still need to consider and what differential diagnosis I can rule out. Like if the patient is complaining of chest pain which is retrosternal, I'm thinking less about pleuritis. Pleuritis is often lateralized. I'm thinking more about angina, esophageal disorders, or acute pericarditis, or aortic dissection. Now in that case, I will also look at the nature of the pain. If it is sharp and penetrating, then angina is less likely. It is more likely esophageal perforation, acute pericarditis, or aortic dissection. So that is how my differential diagnosis starts narrowing down, right? So let's write few key points about each symptom. So anginal pain is usually retrosternal. This is squeezing in nature. It is not sharply localized, right? And it gets aggravated by exertion, and it gets relieved by rest or nitrates. Okay. The esophageal disorders are often retrosternal in nature of pain, and they get often aggravated by food, because when you eat food, if esophagus is already inflamed or torn, it will worsen the pain. Okay. Then acute pericarditis. Acute pericarditis pain is also retrosternal, but this pain is increasing on lying down and during inspiration. And in terms of nature, we know that it is sharp penetrating type of pain. This is penetrating type of pain, and it decreases in on sitting up and during expiration. While the pain of angina has no relationship with posture and breathing, acute pericarditis pain does have some relationship. So at the end of examination and history, you see a pattern emerging, whether that particular pattern fits into anginal pattern, esophageal disorder pattern, pericarditis pattern, right? So from there, you can narrow down your differential diagnosis. And then we get into the examination. Examination adds some more information which can help me to further narrow down my differential diagnosis. For example, we will look at BP and vitals. And if you notice that patient's BP is low, can inflammation of the costochondral junction, the costochondritis, cause low BP? Unlikely. Simple inflammation of the pleurae cause low BP? Unlikely. So among our list of differential diagnoses that we had mentioned, what all can cause low BP? If I have a massive myocardial infarction, MI can cause low BP. Okay. Aortic dissection can cause low BP. Maybe if I have esophageal perforation like Boerhaave syndrome, I might have bled a lot of blood, then it can cause volume loss and low BP. If I have a patient in hypotension, it helps me to further narrow down differentials. In that case, I would not be thinking of simple diseases like costochondritis or GERD or diffuse esophageal spasm. They won't cause hypotension, right? If patient is quite unstable, if there is hypotension, the possibilities are, now you can think of a massive myocardial infarction or massive MI, particularly MI involving the right side of the heart, like right ventricle. The chances of hypotension is high. Second possibility is esophageal perforation, or what we call as Boerhaave syndrome. The third possibility is it can be also aortic dissection or rupture. If the patient is hemodynamically stable, whatever differential diagnosis list I had at the end of history will remain. But if he is unstable, some of them can be confidently ruled out. Costochondritis or pleuritis is unlikely to cause hypotension. The GERD is unlikely to cause hypotension. So those can be now ruled out. Okay. What other findings I can get on examination? If there is localized tenderness, wherever patient is saying I have pain, if I press there and he experiences the worsening of pain because of the press, that is localized tenderness, this can't be MI. In MI, the pain is deep seated because of the myocardial ischemia. It's not superficial. So pressing doesn't increase or decrease the pain. In pericarditis, it does not increase or decrease the pain. In esophageal perforation or aortic dissection, it does not increase the pain. Where I can have increase in the pain on pressing, if I have costochondritis. If the rib and the costal cartilage junctions are inflamed, if you press there, it hurts them more because they're inflamed and they're superficial structures. So localized tenderness is present in patients with costochondritis. So this can help you to identify costochondritis as well. And then you can also get some more clues on auscultation. Like for example, if I have pleuritis, if the pleurae are inflamed, as such the pain is lateralized, as we know, whichever side of the pleurae is inflamed, there will be the pain. And those pleurae during inspiration, when they rub against each other, they make a scratchy noise. And that noise, we call it as pleural rub. So on auscultation, you can hear pleural rub if pleuritis is present. While the respiratory system auscultation will not give you any abnormal sounds if you have the myocardial infarction or if you have aortic dissection, right? And on CVS auscultation also, you can get some potential clues. If you have acute pericarditis, the inflamed pericardium, when they rub against each other, they make a triphasic scratchy noise. We call that noise as pericardial rub or pericardial friction rub. So you can have pericardial friction rub if patient has acute pericarditis. If patient has acute pericarditis. Now there's one more question that your teachers might ask you during your practical examinations or sometimes in the emergency room itself. How do you differentiate? Because pleural rub and pericardial rub are both the sounds produced by rubbing of two membranes which are inflamed. So how do you differentiate between pleural rub and pericardial rub? Because pleuritis pain and pericarditis pain both get worse on inspiration and both get better on expiration, because inspiration increases the chance of the pleurae rubbing against each other, pericardium rubbing against each other. Okay, so I will tell you a note so that you can answer your teacher's question also. Pleurae rub, the two layers of pleurae rub during inspiration because the lungs expand and the two layers come closer to each other. Like this is the lung and it is lined by one parietal pericardium and a visceral pericardium and another parietal pericardium. And when the lung expands, the two layers, this layer and this layer, approximate each other and rub. In case of the pericarditis, the two layers of pericardium are rubbing against each other. But as long as heart is contracting, the pericardium will be rubbing. The rubbing increases on inspiration. That's why pain increases on inspiration. But in case of the pleural rub, if you ask the patient to hold the breath, the lung is not expanding anymore, the pleurae don't rub anymore, and the rub disappears. So pleural rub decreases or disappears on pleural rub decreases or disappears on breath holding, while the pericardial rub persists on breath holding, because you can't stop the heart. It will continue to contract and you will continue to hear pericardial rub. pericardial rub persists on breath holding. So a lot of differentiation is possible on the clinical grounds. We don't have to be reliant on investigation always. So by this time, once the examination is completed, you might have a clear pattern emerging, like this is fitting into the anginal pain because the pain is retrosternal, it is getting worsened on exertion, or it is getting relieved by rest or nitrates, it is squeezing in nature, then it is fitting into the anginal type. If the pain is sharp or penetrating with profound hypotension, if it is sharp and penetrating with hypotension, I would think about the esophageal rupture or the aortic dissection. If it is sharp and penetrating, but patient appears to be hemodynamically stable, and at the same time, the pain is worse on inspiration and better on expiration, worse on lying down and better on sitting and leaning forward, then it is fitting into acute pericarditis pattern. So at the end of complaint, history, and examination, you will have figured out one topmost priority diagnosis and some 2 or 3 closely related differentials. So we took chest pain as a complaint and we have come to a very narrowed down differential diagnosis. And this is what every doctor is supposed to do in the emergency room. Quickly take the history, do some quick examination, and have a narrowed differential diagnosis. Just imagine that if I am not doing this exercise, I am just taking chest pain, patient has chest pain. In that case, just think about the number of investigations I need to do to arrive at the diagnosis. For angina, I need to do ECG, echocardiography, and maybe coronary angiography. For esophageal disorders, I need either a barium swallow study or the endoscopy, CT of the chest. Then for costochondritis, clinical diagnosis is very difficult because if I'm not taking the history, then I have to do PCR for n number of viruses. For acute pericarditis, again I need ECG, maybe echocardiography again. For aortic dissection, I need to do the CT of the chest and the abdomen. For pleuritis, plenty of investigations, including if there is some effusion, aspiration of the fluid. And when all this data arrives, maybe based on the report, I will be able to diagnose. But if I take the good history, try to narrow down my differential diagnosis, I will be left with only 2 or 3 possible differentials, and I have to do only 2 or 3 maximum investigations to finally arrive at the diagnosis. So by doing so, what are we doing? We are minimizing the cost of care for the patient. See all these number of investigations done, it will be like 1.5 lakh rupees just spent before the arrival of the diagnosis. To take the history, you narrow down the investigation, within 3-4 thousand rupees, the patient diagnosis is reached upon. And a lot of time is saved before diagnosis arrived. Otherwise, if I'm dependent on all these investigations and when everything accumulates, it's like 2-3 days. And if it is an MI, patient is already gone. If it is aortic dissection, invariably patient will be dead by the time your reports arrive. So that's why history taking is extremely important. Okay. So now we have learned a little bit about recognition of a patient presenting with chest pain into different patterns. We will spend the remaining time on talking about the topic proper for today, which is acute coronary syndrome focused on STEMI. Okay, so how we recognize acute coronary syndrome and how do we approach further? So let's identify the pattern of acute coronary syndrome. What's the pattern of angina? So if patient has got angina, anginal pain is, as we know, it is a retrosternal chest pain which is squeezing in nature, and it may be referred to anywhere, most commonly left shoulder, but also other shoulders, I mean the right shoulder as well, or epigastrium, neck or jaw, as we have already discussed, neck or jaw or tongue, anywhere. Okay, and often patients may have relieving and aggravating factors in the form of exertion and nitrates or rest. Now my question is, angina, as I have already told you, can occur because of various conditions. It can occur because of something called as stable angina. It can occur because of unstable angina, NSTEMI and STEMI. These 3 conditions are considered as critical because basically they are nothing but one disease. When the coronary artery gets blocked, significantly blocked, and the blood flow decreases, first you will have severe ischemia and that results in unstable angina. But after some time, if you don't act, the myocardium starts dying. When little myocardium dies, you will have the myocardium dead. That means you have MI, myocardial infarction is there, but not sufficient depth of the myocardium to give you ST elevation on the ECG. So that becomes NSTEMI. And when full thickness of the myocardium dies, then you can see ST elevation, then it becomes STEMI. So this unstable angina to STEMI is just spectrum of one disease, while stable angina is a different spectrum. So exactly what is going on? Let me take just 2-3 minutes on the pathophysiology. All of us right now are taking one small step every day towards developing MI in future. Means the pathology that is responsible for giving you MI begins past your teenage, and every day we take one tiny step towards that final outcome. Exactly how? Past teenage, inside our arteries, including coronaries, there is deposition of cholesterol. And where does deposition begins? Deposition begins in the intima, just underneath the endothelium. So imagine this green layer is endothelium, and underneath this endothelium we start depositing cholesterol. And when we deposit cholesterol, we call that as an atheroma or an atheromatous plaque. Right now all of us have some degree of cholesterol deposits in our coronaries. Some of you may be having more, some of you may be having less. Who has more, who has less depends on various factors: your genetics, your dietary practices, your lifestyle, whether you're physically active or sedentary, whether you're in calorie surplus or you're in calorie deficit. All those your lifestyle factors, whether you smoke or not, whether you drink or not. Those factors, based on those factors, some of you may have more bigger volume of atheromatous plaques, some of you may have smaller volume of atheromatous plaque. But atheromatosis occurs as part and parcel of aging, but progresses very slowly. So some of you may not develop critical blocks throughout your lifetime, and that's why you never get an MI. But some of you may develop critical blocks. Some of you might develop critical block in your 30s, some in 40s, some in 50s, depending on your lifestyle. But atheromatosis does occur in everyone at some rate. Okay. So when the atheromatous plaque progresses to the point where there is significant reduction in the coronary flow, then the myocardial oxygen demand that occurs or that increases during exertion is not met. Means all of you now have some block. Your parents also have some blocks. They don't have any symptoms as of now, because even with the blocks, the coronaries are still able to give the sufficient blood flow to the myocardium. So they don't have any demand and supply mismatch. You might be having 5%, 10%, 15% block. Despite the block, the blood flow is sufficient enough to keep your myocardium healthy. And myocardium has two levels of demand. One at rest. Right now, me, you, all of us are just sitting and watching, so we're at rest. It is myocardium is doing work and it is having some X amount of oxygen demand. But after the class, if you start running or you start lifting some weights or do some major physical activities, heart needs to do more work, and myocardial oxygen demand increases. So you have a rest myocardial oxygen demand and peak exertional demand. At this point of time, both of your myocardial oxygen demands are met by your coronaries in spite of having blocks. That's why neither at rest you have pain, nor on exertion you have pain. But as time progresses and the atheromatous plaque becomes bigger, the blood flow gets reduced, and at that point of time it may be able to meet your rest demand but not able to meet your exertional demand. At rest, whatever amount of oxygen your heart needs, it is able to give, but when you start exerting, it needs more. That much demand increase is not possible because the coronaries are narrow. Then you start experiencing the pain only on exertion, and what we call that pain as, we call it as stable angina. So in stable angina, pain only comes on exertion, and as I take rest, myocardial oxygen demand decreases, and as the myocardial oxygen demand decreases, the mismatch between the demand and supply gets balanced and the pain disappears. So stable angina patients will have chest pain only on exertion, and it gets promptly relieved by rest. So as long as this is going on, patient is still on the safer side. But one day a critical event happens in the life of this patient. What is that critical event? This atheromatous plaque that we are talking about ruptures, and once the plaque ruptures, that's where the problem starts. So plaque sitting quiet there for some time, but it is expanding. One day it ruptures. And once the plaque ruptures, because the plaque is just placed underneath the endothelium, the rupture leads to endothelial injury. And this great guy Virchow had given us a triad of coagulation. Whenever there is endothelial injury or stasis or hypercoagulability, there is increased risk of developing clot, and we call that as Virchow's triad. So one of the component of the triad is now given to the patient. The endothelium, we have this so-called von Willebrand factors hidden from the circulating platelets underneath the endothelium. But once you remove the endothelium, they are exposed. And once the von Willebrand, the lumen becomes further narrowed. And now whatever blood flow I'm able to achieve may not be enough to meet your demand of myocardial oxygen at rest. Earlier, before the plaque rupture, my rest demand was met. My only problem was when I start exerting, my demand increases and I'm not able to meet that demand. So I used to experience pain. But once the plaque ruptured, platelets came, my demand of rest itself is not met. So I start experiencing pain at rest. The problem doesn't stop there. After this myocardial, after the platelet plug formation, body starts depositing what we call as fibrin there. Once I add a little fibrin, flow gets further reduced. Now almost 85, 90, 95% block. Flow is severely compromised. And now the blood flow is not enough to keep the myocardium alive. At least when I just had platelets, I was able to keep the myocardium alive. Patients were experiencing chest pain at rest, but infarction hadn't occurred yet. We will call that stage as unstable angina. But now that fibrin started depositing, the myocardium starts dying. And the death of the myocardium begins from the endocardial side. Like if this is the heart we are looking at, imagine this is the myocardium. Inside we have the endocardium, outside we have the pericardium. And because the blood vessels run on the surface of the heart and enter from outside to inside, if I create a block, whatever little blood that comes to the myocardium gets taken up by this part of the myocardium. So it can survive a little longer. But the distal part, this part can't get the blood supply and that dies first. And can I now say that patient has developed infarction? Yes, myocardium is dead. Where the death occurred? The myocardium underneath, just beneath the endocardium. So can I call it as subendocardial infarction? Yes, we will call it as subendocardial infarction. But when the infarction is only on the subendocardial side, it doesn't show up on the ECG as ST elevation. MI is there, but ECG doesn't show it. We will call it as non-ST elevation MI. You act now, good. If you don't act, slowly the infarction extends to involve the full thickness of the myocardium, because slowly there will be more fibrin added, and as more fibrin gets added, the block becomes critical. Now the blood flow is almost nil and the entire thickness of the myocardium dies. We will call this as transmural infarction. And now the ECG starts showing up as ST elevation. So where the problem actually began? When the endothelium ruptured, plaque ruptured, initially platelets, you got unstable angina. Then little fibrin, you got subendocardial infarction. We call it as NSTEMI. More fibrin, near total or complete occlusion, the entire thickness of the myocardium dies, you develop STEMI. So from unstable angina to STEMI, patients have just minutes to few hours journey. Means within few minutes, unstable angina will become NSTEMI, NSTEMI will become STEMI. So within minutes to few hours. While patients can live tens of years with the stable angina, as long as the plaque is not ruptured, is not a big deal. But one day plaque ruptures, the things progress too rapidly. Within minutes, the fate of the patient changes. So that's why unstable angina, NSTEMI and STEMI are considered as acute coronary syndrome, while stable angina is considered as a chronic coronary syndrome. So now you should tell me, what is the most important question that you want me to ask when someone complains of chest pain and the pattern appears to be anginal, like it is retrosternal, squeezing in nature, maybe referred to left shoulder. So it looks like anginal, it is less likely to be acute pericarditis or dissection of esophagus or the dissection of aorta, where you generally get sharp penetrating chest pain. So those things are not there. So you're considering it as anginal. What is the next important question you want to ask the patient? Atul Singh, yes, endocardium can extract the oxygen from the cardiac chamber. Yes, the single most important question that you need to ask is whether the pain started on exertion or whether it started on rest. If the pain started on rest, that means it is not stable angina. It is either unstable angina, or the condition has progressed to cause NSTEMI, or it has progressed to cause STEMI. So if you become an intern and you have a patient with chest pain in the emergency room and for you it looks like anginal pain, the first question I want you to ask is, when did the pain start? What were you doing? If the patient says, I was running on the treadmill and the pain started, versus the patient who says, sir, I was watching TV and then suddenly pain started. The patient watching the TV and pain occurring then is more likely to be a critical case than someone who started developing chest pain on the treadmill. But also you should make sure that if it is truly stable angina, then the pain gets relieved on rest. If it is not relieved on rest, it is still again a acute coronary syndrome, right? So that's why once you document that this is angina, you need to ask whether it is rest angina. If it is rest angina, it is an acute coronary syndrome, or angina not relieved by rest within 5 minutes, relieved by rest within 5 minutes, relieved by rest or nitrates within 5 minutes. All of these cases are equal to acute coronary syndrome. Acute coronary syndrome means you're thinking about what all possibilities. You're thinking about either unstable angina or NSTEMI or STEMI. Now, within this acute coronary syndrome, all of them are emergencies, need attention immediately. But within this, unstable angina is on the milder end of the spectrum and STEMI is on the more severe end of the spectrum, because in unstable angina, there is no infarction. In NSTEMI, there is subendocardial infarction, and in STEMI, full thickness infarction is there, right? I will just write it here for your reference. In unstable angina, there is no infarction. That's why the name is angina, not MI. But in NSTEMI, there is subendocardial infarction. Subendocardial infarction. And in case of STEMI, there is transmural infarction. Transmural infarction. So STEMI is the more severe form and unstable angina is on the milder end of the spectrum. Now I want to know, okay, patient came with chest pain, I took history, I did some quick examination and I concluded it is anginal. I did inquire about the onset of pain, whether it is rest angina or exertional angina. Exertional angina relieved by rest, so stable angina. But rest angina or exertional angina that is not getting relieved by rest is equal to acute coronary syndrome. Now I want to know, which one is it? Is it unstable angina, NSTEMI or STEMI? So what should be my next step? Of course, we will always concentrate on ruling out the worst scenario first. And what is the worst scenario here? STEMI. How will I recognize STEMI? I have to have ST elevation on the ECG to call it as STEMI. So my next step is going to be ECG. So any patient with rest angina or angina that is not getting relieved by rest, you should go ahead with ECG. A single ECG may not pick up the changes, so you have to go ahead with serial ECGs. You might have to repeat ECGs at intervals. Okay, once you get the ECG, you will see whether ECG shows typical ST elevation or not. Means ECG has n number of causes for ST elevation. What I'm looking for is the ST elevation suggestive of STEMI. If it is suggestive of STEMI kind of ST elevation, we will call it as typical ST elevation. So if I have typical elevation, ST elevation present, then it's clearly a case of STEMI. If I don't have typical ST elevation, I can have atypical ST elevation. Just because there is some ST elevation is not equal to STEMI. To call it a STEMI, typical ST elevation should be there. What is it? Can a MBBS student recognize it? Don't worry, I'll make it easy. You will be able to recognize every case of MI in your emergency room. It will not take much time for us. But first, let's go through the algorithm. If there is no typical ST elevation, then STEMI is as of now ruled out. We think about unstable angina or NSTEMI. Now, how will I differentiate between the two? Just remember, in unstable angina, there is no infarction yet. It will occur after some time and it will become NSTEMI. But as of now, if it is unstable angina, there is no infarction. But in NSTEMI, there is subendocardial infarction. So if I can have one test which can help me to identify the presence of infarction, that can help me to differentiate between unstable angina and NSTEMI. So what is that one test? The biomarkers of myocardial injury, like the troponins or CKMB. So that's why if the ECG doesn't show up with ST elevation, we go for troponins. We will go for cardiac troponins, troponin T or troponin I. These are biomarkers of myocardial injury. And if the troponins are elevated, that means myocardial injury has occurred, means MI has occurred. And probably it is not transmural, that's why you did not see ST elevation, but MI is there. That evidence is there in the form of raised troponin. Then I can call it as non-ST elevation MI. But there is rest angina. ECG did not show ST elevation. Neither troponins are elevated. That means infarction has not occurred, neither subendocardial nor transmural. Then you have unstable angina. Then you have unstable angina. Okay, understood. Patient presented with chest pain. I took history to conclude this as anginal type of pain based on Levine sign, squeezing in nature, radiation reference, and all of that. Once I concluded this is anginal, I will see whether it is exertional angina or rest angina. Exertional angina relieved by rest is typical of stable angina, but something that is at rest or not relieved by rest is acute coronary syndrome. I do an ECG. If it shows typical ST elevation, it is STEMI. No typical ST elevation on serial ECGs, then it is not STEMI. I look at the cardiac troponins. If they are elevated, it is NSTEMI. If they are also not elevated, it is unstable angina. And remember, recognition is important, because unstable angina, if not treated, within few minutes to few hours, it will become NSTEMI. If NSTEMI not treated, within few minutes to few hours, it will become STEMI. Just a progression of the same pathophysiology. It's just that the patient is presenting in different time frames. If they present early, they will be in unstable angina stage. If they present little late, they will be in NSTEMI stage. If they present little more late, they will be in STEMI stage. Many times, delay in diagnosis by doctors can also contribute to unstable angina being recognized at the stage of STEMI. When patient presented, he may be unstable angina, but we did not expedite the process of reaching the diagnosis. And that's why by the time we finally conclude that this is a case of ischemic heart disease, patient might have progressed to STEMI. So that's why quick history taking and quick process of examination and quick process of investigation makes literally a lot of difference to the patient's chances of survival. Okay. Now the question is, sir, how do I recognize that there is ST elevation in the ECG? Because recognizing the normal waves itself is so difficult. So let's go through an ECG and learn how to recognize this STEMI. See whether you recognize ventricular hypertrophy or not, atrial hypertrophy or not, whether you recognize a first degree AV block or not, doesn't matter, or whether you recognize LBBB or RBBB or not, doesn't matter. It's not a do or die situation for the patients. But missing out on MI can literally cause the death of the patient, and that's why every doctor should know to recognize ST elevation MI. Okay. So how do I recognize ST elevation MI? The typical ST elevation of MI has certain characteristics. What are those characteristics? The first characteristic is there should be J point elevation. There should be J point elevation. Second, the ST segment elevation should involve at least two leads. ST elevation in more than or equal to two anatomically related leads or contiguous leads. ST elevation in more than or equal to two contiguous leads. And third change is presence of reciprocal changes. Reciprocal changes. When these three criteria are satisfied, you can call it as ST elevation typical of STEMI. The first thing we need to recognize is what is this J point. So when you take an ECG and see the waves, you know that you will have a P wave representing the atrial depolarization, PR segment representing the AV nodal delay, and once the ventricle start getting depolarized, you get this Q, R and S complex. And after that you have this ST segment, and then you will have T wave. To call it as ST segment elevation, this segment should be elevated. Now what am I using as a referral point for elevation? The referral point is PR segment. So in comparison to PR segment, the ST segment should be above. Then it is ST elevation. And to be called as typical ST elevation, you should have J point elevation. Now what is this J point? The J point refers to the end of QRS complex. J point is nothing but the end of QRS complex. Means this QRS wave that we see, wherever it ends, that's the J point. Now in some leads in the normal ECG, the S wave is not clearly visible. It might end with R itself. So then you can count end of R as the J point. In some leads, you will clearly see S wave. So in that case, the end of S. So whether the QRS ends with R or ends with S, the end of QRS is your J point. So in this picture that I have drawn, where is the J point? We can count this point as the J point. Now your question is, sir, how will I identify that the QRS ended there? You can clearly see an angle being formed wherever the QRS ends. Like here you can see it is forming a angle. It's not continuing further, right? It's forming an angle here. So that point is what we call as J point. The J point should be above the level of PR segment. Because sometimes you can get ST elevation where the J point is on the baseline, it is not changed, and then rest of the segment gets lifted up. So there is ST segment elevation, but the J point is on the baseline. Then it is not typical of STEMI. It could be early repolarization or some other causes like drug-induced ST elevation. To call it as ST elevation typical of STEMI, the J point should be lifted above. Like if I have ST elevation like this, here you are seeing an angle being formed, that means J point is elevated. Okay, so J point should be elevated, and you should see such elevation in at least 2 leads which are anatomically related. So first let's try to see if we can recognize the J point elevation in a ECG. So I have lined up one ECG here, and I want you to tell me whether the J point is elevated in lead 2 or not. I hope you can clearly see the image and tell me whether J point is elevated or not. What is J point? J point is end of QRS. So first let's try to learn the end of QRS. So when I see here somewhere some faint P wave, if you're not able to recognize, not a big deal, because our interest is only on J point now. So the one tall positive wave we all know is R wave. So R is going up here and then it comes down. Okay. So when it comes down, this is end of R. Then probably this is going to be my S wave. And this is where I can see an angle being formed, right? It is forming an angle here. Do you all agree that there is an angle being formed there? So if there is an angle being formed there, I can count this point as the J point, right? So this is literally my J point. And if that point is the J point, this point, you're able to see, right? Let me highlight again this point. This point is where you can see an angle being formed. The first positive wave, tall positive wave is R. The next one, this V-shaped, can be counted as S, and it ends here forming an angle, and then rest is the T wave. So this point is the J point, and this J point, when compared to the PR segment, it is clearly above. That means there is J point elevation, and then rest of the ST segment is elevated. So there is J point elevation in lead 2. What about the lead 3? What about lead 3? P here. Can you tell me whether the J point is elevated in lead 3? I hope you are able to. Guys, you have audio issues, and just let me know. And if you want me to repeat from some point, I'll repeat it. Let me know. Okay. So here, this is the Q wave, and you can see the R wave going up, and it comes down, and this is my S wave, right? So this part is the S wave, and I can clearly see an angle being formed here. Do you see an angle here? There is an angle being formed. Yes. So that means this becomes my J point, and this J point is definitely above the PR segment. So J point elevation is there in lead 3 as well. But can I say so about the lead AVL? Is there any J point elevation in lead AVL? If you see lead AVL, okay guys, you still have audio issues? Okay, so in lead AVL, this is my P wave, PR segment. After the P wave, the next positive wave is R. So R goes up, then comes down, and this wave is my S wave. Where is the S ending? I can see an angle being formed here. That means this point becomes my J point. So this J point, when I take PR segment as a referral point, it is below it. So you can say that in lead AVL, there is ST depression and not ST elevation, right? Okay, so we learned to recognize the J point elevation. What is the J point? Okay, so to call it as typical ST elevation, J point should be elevated, should not be sitting on the baseline. Okay, fair. Then I made a statement saying that the ST elevation should be documented in at least 2 contiguous leads. And there comes a question, sir, what do you mean by contiguous leads? I did not use the term continuous leads. In the ECG 1, 2, 3, these are continuous leads. V1, V2, V3, V4, V5, V6, these are continuous leads. And of course, I'm not Shashi Tharoor to complicate the English. The contiguous leads has a meaning. Contiguous leads here refers to the leads which are representing the same part of the heart. So for further interpretation, I need to know which leads represent which part of the heart. So you know that heart is not vertically held in the mediastinum. It is positioned little slanted. It is resting on the diaphragm. Okay. So if you think of this as the heart, okay, let's take this as the heart. The heart is positioned slanted like this, resting on the diaphragm. So it has an inferior surface which is resting on the diaphragm, and because it is tilted, I don't have a superior surface. I have an inferior surface resting on the diaphragm, but slight tilt means it has a lateral surface. And the one you see on the front, this is anterior surface, and the one behind is posterior surface. So heart has 4 surfaces: an inferior surface resting on the diaphragm, a lateral surface opposite to the inferior surface, and anterior surface that you see when you cut the chest and open for the first time in the anatomy, and a posterior surface which is hidden behind. So heart has 4 surfaces, and we have a representation of some of these surfaces. So this part, which is like the bottom part, which is facing the diaphragm, this we will call it as inferior wall of the heart. And inferior wall is represented on the ECG by leads 2, 3 and AVF. So if I have inferior wall MI, I will have ST elevation in lead 2, 3 and AVF. And because they are representing the same wall of the heart, to call it as a typical ST elevation of STEMI, at least 2 of these leads should show ST elevation. If I get ST elevation in only lead 2 or only AVF, it's unlikely to be typical STEMI kind of ST elevation. Okay, now opposite to this inferior wall, we have this wall. I can label it as lateral wall. This will be called as lateral wall, and it is represented on the standard 12 lead ECGs by lead 1 AVL, V5 and V6. So you can imagine that these leads are nothing but cameras looking at these walls of the heart. So inferior wall 2, 3 AVF are looking at it. Lateral wall 1 AVL, V5 and V6 are looking at it. And if this is the heart we are looking at, if you place a camera in front, imagine that this is a transparent bottle. If you place a camera in front, you can see the front of this bottle directly, but because it is transparent, you can also see the back of this bottle through the front wall. So this lateral wall leads are not only looking at the lateral wall directly, but they are also looking at the back of the inferior wall. So we can say that inferior leads and lateral leads are reciprocal to each other. It means lateral wall leads look at the lateral wall directly, and indirectly they also have a look at the inferior wall. And the inferior wall leads are looking at the inferior wall directly, but they're also looking at the back of the lateral wall. So in that case, if I have inferior wall MI, it will show ST elevation in inferior leads. And if I'm looking at the back of inferior leads, then lateral wall should show ST depression. And these changes is what we call as reciprocal changes. So if I have inferior wall MI, lateral wall should have ST depression. If I have lateral wall MI, inferior wall lead should show ST depression. Okay. Apart from that, the front side of the heart, this front side, we are going to call it as anterior wall. Anterior wall, and the anterior wall is represented on the standard 12 lead ECG by leads V3 and V4. And somewhere hidden behind this anterior wall, you have this interventricular septum, or in simple words, septum. And we have leads representing septum as well, and those will be V1, V2. V1, V2 for septum, V3, V4 for anterior wall, 2, 3 AVF for inferior wall, and 1 AVL, V5, V6 for lateral walls. In the standard 12 lead ECG, we have good representation of inferior wall, anterior wall, septum, and lateral wall. But then we don't place any leads on the back to document posterior wall. So we don't have a direct representation of posterior wall on the standard 12 lead ECG. And also you should be aware that some part of the right ventricle gets missed out on the standard 12 lead ECG representation because it is buried behind the sternum and its electrical activity is not documented by the standard 12 lead ECG. So whatever regular ECG we take, we don't see the posterior wall in that ECG, and we don't see some part of the right ventricle. Okay, is that clear? So you call it as contiguous leads if they are representing the same wall. Means to call it as two contiguous leads showing ST elevation, that means either I should have ST elevation in one AVL or V5, V6, not like there is ST elevation in lead 1 and lead 2. These are continuous leads, but they are not representing the same part of the heart. So I can't call them as contiguous leads. Okay. So to call it as typical ST elevation, there should be ST elevation in at least two contiguous leads representing the same part of the heart. And if ST elevation is seen in one set of leads and those particular leads have a reciprocal lead, like inferior wall as lateral as reciprocal leads, in that case lateral lead should show ST depression. And when these criteria are met, you know, it is a typical case of STEMI in your hands. So let's write down the ECG leads and which wall they represent, and also the blood supply of those walls. The inferior wall, as I've already told you, is represented on a standard 12 lead ECG by lead 2, 3 AVF. And because the inferior wall and lateral wall are looking at each other from the diagonally opposite direction, the lateral leads, that is mainly 1 and AVL, act as reciprocal leads for the inferior wall. And I can say the same for lateral wall. Lateral wall is represented by 1 AVL, V5, V6 as main leads, and inferior leads, that is 2, 3 AVF, act as reciprocal leads. 2, 3 AVF act as reciprocal leads, while anterior is V3, V4 and septum is V1, V2. Now anterior should have posterior wall as the reciprocal leads, right? Behind this should be reciprocal lead for the anterior, but in a standard 12 lead ECG we don't have any posterior wall representation, so anterior leads don't have reciprocal leads. 2, 3 AVF are acting as reciprocal leads for lateral. Anterior does not have, and septum does not have reciprocal leads. Now, if at all I am suspecting the possibility of posterior wall MI, in that case I have to do an additional ECG by putting the leads on the back to capture the electrical activity of the posterior wall of the heart. And when I put additional leads for the posterior wall on the back, we will label them as, see, we have already labeled the precordial leads as V1 to V6. So what am I left with? V7, V8, V9. So we'll label them as V7, V8 and V9. Similarly, if I'm suspecting the right ventricular MI of that part of the right ventricle which is not well represented on the standard 12 lead ECG, then I have to put a right sided precordial lead, means put one lead on the right side which captures the electrical activity of the right ventricle. We will label it as R because we are putting it on the right side of the chest, not on the regular left side. And it is V because it's a precordial lead, not a limb lead, and we will call it as RV4, or some of the books mention it as V4R. You can either call it as RV4 or V4R, an additional lead in addition to the standard 12 lead ECG. Okay. Now I'll give you an ECG. You should tell me whether this patient has ST elevation MI or not. So he came to us with the chest pain in the emergency room. I got the history. He says it is central squeezing going to the left shoulder. Typical angina pattern. I did ask him, when did the pain start? He says, I was having food and suddenly I started experiencing pain. So it is a rest pain. This is not exertional pain. It did tell me that he had history of the exertional pain in the past and he was taking some nitrates as a pain relievers. He was on aspirin, clopidogrel or the statins. But now the pain started at rest itself. Doctor had told me that if you get a rest pain, you should report immediately. So that's why I have come here, sir. Okay. I got an ECG done because if it is rest angina, it is acute coronary syndrome. It could be unstable angina, NSTEMI or STEMI. I got an ECG done and ECG is in front of you. If you say, sir, yes, this ECG has ST elevation typical of STEMI, then the diagnosis is STEMI. If you say no, sir, then STEMI is less likely. I have to now think about unstable angina and NSTEMI. For that, I will go ahead with troponins. Now, what do you notice here? So when I see lead 1 and look at the J point is the end of QRS. You will notice that PR segment, R goes up, comes down, and once it comes down, it becomes S. And this S comes up and ends here, right? Here it is ending. This point is where it is ending. I hope you are able to see that. If this point it is ending, it becomes J point. And for me, the reference point is PR segment. This J point is clearly below the PR segment. That means there is ST depression in lead 1. When I look at lead 2, we have already discussed this. Lead 2, the J point appears to be above the PR segment. This is where an angle is being formed between the end of QRS and the next segment. So this point is J, it is above the PR segment. So in lead 2, there is ST elevation. In lead 3, you can see this Q, you can see R going up, coming down, it becomes S. Again, S going up, it ends here because an angle is formed here. So this point where angle is formed becomes my J point. And this point is definitely above the PR segment. So there is ST elevation in lead 3 as well. Okay. Then what about AVL? AVL we have discussed. You can clearly see that this is PR segment. First positive wave after P is R. Then next downgoing is S. S comes up and ends here. An angle is formed here. And this point becomes J point. Clearly it is below the PR segment. So it is ST depression. But in case of AVF, Q, R goes up, comes down. This becomes S, goes up and forms an angle here. So this point becomes my J point, that is clearly above the PR segment. So there is ST elevation in AVF as well. And when I scan through other leads, I also notice the ST depression here because J point is here in V2, right? These are my observations. So do we have J point elevation? Yes, we have J point elevation. Do we see such elevation in 2 or more than 2 anatomically related leads? Yes, we saw ST elevation in lead 2, 3 and AVF. They're all representing the inferior wall. So 2 leads representing the same wall is showing ST elevation. J point is elevated, 2 contiguous leads are showing ST elevation. So 2 criteria are already met, right? And if I'm seeing ST elevation in 2 or more than 2 contiguous leads, which is satisfied in this case, if this particular set of leads have a reciprocal lead, there should be ST depression. And what are the reciprocal leads for 2, 3 AVF? As we have written here, the reciprocal leads for 2, 3 AVF are going to be 1 and AVL. So 1 and AVL are supposed to show ST depression. If 1 and AVL is showing ST depression, 1 and ST depression, then it is reciprocal change which is present, right? So do we have ST depression in 1 and AVL? Yes, we did saw that 1 shows ST depression. You can see the PR segment here and J point below that, right? PR segment here and the end of S is here. This is the J point. J point is clearly below the PR segment. And also in AVL, which is very, very clear. You can see a PR segment, R going up, S coming down, S ends here. This is a J point. So there is a clear ST depression. So you are seeing ST depression in 1 and AVL. That means this ECG has J point elevation, has two or more than two anatomically related leads showing ST elevation, and there is also ST depression in one and AVL, which is nothing but reciprocal changes. Reciprocal changes. So it meets the criteria to be called as typical ST elevation, and thus we have STEMI in this case. So what came with the chest pain, you have recognized it as STEMI. Now, as a good doctor, I also want to expect from you that you should be able to tell me which blood vessel should have been blocked to give you this inferior wall MI, because 2,3 AVF is inferior leads, right? So inferior leads are showing ST elevation. That means our diagnosis here is inferior wall MI. Inferior wall MI. Additional observation, I also saw ST depression in lead V2, right? ST depression in lead V2 as well. And I guess some extent minor ST depression in lead V1 also. V2 is very clear, so I will document that here. There is ST depression in lead V2 also. Okay, so we diagnose inferior wall MI. Now, if I know the coronary blood supply, I can predict which blood vessel may be blocked in this patient, and sometimes MCQs are asked on this, so we should be able to answer that as well. So let's discuss about the coronary blood supply also. Okay, if this is my heart, okay, the coronaries originate from the aorta, right? So this is where I have the aorta. Coronaries originate from the aorta, and we have two major coronaries, one originating from the aorta and supplying the mainly right side of the heart, we will call it as right coronary artery, and another supplying mostly left part of the heart, we will call it as left coronary artery. So we have two major coronary arteries, one RCA and the other one is LCA, right? Let us call this as right coronary artery and this is as left coronary artery. Some books also call it as left main coronary artery because soon after origin it divides into two. Okay, now this right coronary artery is the one which will go and give the blood supply to the inferior wall. So most of the blood supply to inferior wall of the heart comes from right coronary artery. So if you have inferior wall MI, you should be suspecting the possibility of right coronary artery block, right? RCA is the main blood supply to the inferior wall. Okay, now this left coronary artery, soon after the origin, it branches into two. So one branch becomes what you call as left anterior descending and another becomes, so one of them becomes what you call as LAD, left anterior descending, other one becomes left circumflex. Okay, anterior interventricular artery. Why am I calling it so? Because this artery is running in the groove between the two ventricles. There's a groove between right and left ventricle and it runs in that groove. That's why it is also called as anterior interventricular artery. Another special name about this artery is it is also known as widowmaker's artery. Means it kills the man and makes his wife the widow. It's also called as widowmaker's artery. Why so? We'll understand now. So we understand that inferior wall is getting the blood supply from right coronary artery, and this LAD is the main blood supply for most of your anterior wall. So anterior wall gets blood supply from the LAD, and somewhere here you have this interventricular septum, right? The interventricular septum here is also going to get the blood supply. The interventricular septum is also going to get the blood supply from the branches of this LAD itself. So LAD is responsible for taking care of your anterior wall and interventricular septum, and if I block it proximally, I can compromise the blood supply to interventricular septum and anterior wall. And remember, most of the anterior wall is formed of left ventricle and we are totally dependent on left ventricular activity. If left ventricle contracts, then only blood gets pumped and goes to the different body parts. If I kill a large part of left ventricle because of ischemia, then it don't participate in the contraction. So the amount of blood ejected significantly comes down, and that is an MI which often kills people. That's why LAD is also called as widowmaker's artery, because its block can stop interventricular septum from contracting and left ventricular free valve from contracting. So if LV doesn't contract, ejection cannot occur properly. Okay. Now this left circumflex artery. This left circumflex artery, once it originates, it supplies the blood to the lateral wall of the heart. So lateral wall of the heart is getting the blood supply mainly from the left circumflex artery. But after supplying, you can imagine that, okay, this is your heart. So the left coronary artery is supplying the one branch which goes anteriorly as anterior interventricular septal, anterior interventricular artery supplying the anterior wall and the septum. Another branch, circumflex, supplies the lateral wall and then wraps around and goes behind, gives some blood supply to the posterior wall. So left circumflex artery supplies the lateral wall, but in addition to supplying the lateral wall, its branches go behind and supply a bit of posterior wall. And similarly, the branches of this right coronary artery also wrap around and go behind and supply the posterior wall. So you can literally say that posterior wall is receiving the blood supply from the right coronary artery and left circumflex. So both of them are wrapping around and going behind and supplying the blood. Okay, got it? So let's try to put it on a table so that we can quickly relate to it. So blood supply for the inferior wall is coming from right coronary artery. The lateral wall is coming from left circumflex artery, LCX, a branch of the left coronary artery, and the blood supply to the anterior wall is coming from another branch of left coronary artery, which we call as left anterior descending or anterior interventricular or widowmaker's artery. Septum is also getting the blood supply from the branches of LAD itself, while posterior wall receives the blood supply from both the right coronary artery and left circumflex when they go behind and supply it. Main blood supply to the posterior wall comes from right coronary artery, and to some extent blood supply comes from the left circumflex. Right coronary artery is the main supply and circumflex is a minor supply. Similarly, that part of the right ventricle which is part of actually inferior wall but not well represented on the ECG, that is also getting the blood supply from RCA. Okay, now comes the question. If I have inferior wall MI, RCA block. If I have lateral wall MI, circumflex block. If I have anterior wall MI or septal MI, LAD block. If I have both lateral, anterior and septal MI, then probably the left main coronary artery is blocked. That's why circumflex and LAD both are not getting blood supply. Now, when do I suspect posterior wall MI? Please remember, suspect posterior wall MI in all patients with inferior wall MI. Why am I saying so? Because the blood supply to the inferior and posterior wall is same, right? Suspect right ventricular MI in all patients with inferior wall MI because the blood supply to the inferior wall and right ventricle is same. So every time you have a patient with inferior wall MI, it's ideal that we do an additional ECG by putting one right ventricular read, that is V4R, and also by putting V7, V8, V9 posterior leads. And if they show ST elevation, then you not just have inferior wall MI, you have inferior plus posterior or inferior plus right ventricular MI, right? So just make a note that suspect inferior wall MI if you have the posterior wall MI, if you have inferior wall MI, or another thing is, though we don't have a direct representation of the posterior wall on the standard 12 lead ECG, we do have anterior leads, that is V3, V4, we do have septal reads, that is V1, V2, and they can act as reciprocal to posterior. So if I have posterior wall MI, these posterior leads are supposed to show V7, V8, V9 are supposed to show ST elevation, and in that case, because anterior and septal are reciprocal to it, they are supposed to show ST depression, right? So you can make a note that the posterior wall has reciprocal leads in the form of anterior leads, that is V3, V4, and also septal V1 and V2 act as posterior. So you can also think of, if there is ST depression in V1 through V4 anywhere, it can be a reciprocal change for ST elevation MI affecting posterior wall. So in this ECG, what do you think? Because this ECG showed inferior wall MI, and of course we know that it is because of the right coronary artery block. And as I already told you, the same right coronary artery is also giving the blood supply to the part of right ventricle not represented on the ECG, and it is also the major contributor to the posterior wall's blood supply. You might as well have, like if I have blocked it here, inferior wall MI and posterior wall MI and maybe right ventricular MI also, and that's why it calls for additional ECG. Now in this ECG, do you have any potential clue towards the presence of posterior wall MI? Yes, when you see the V2, V2 is showing ST depression as a possible reciprocal change for the posterior wall MI. So in the posterior leads V7, V8, V9, you might have had a ST elevation. So if I do an additional ECG with the posterior leads, it will show ST elevation. I don't have the image right now, but in one of my Instagram reels I have posted the similar patient story where they presented with inferior wall MI, but when we got an additional posterior lead ECG V7, V8, V9, we did notice ST elevation there, and in that ECG also anterior leads V3 and V4 had shown ST depression. Here V2 is showing ST depression, right? So now here this should be considered as possibility of reciprocal change for anterior wall, reciprocal for posterior wall MI, and that's why the next step here should be, next step is additional ECG with posterior leads. The PDF will be shared soon. Posterior leads, which is going to be V7, V8 and V9, and that is where my diagnosis becomes completed. So today we have learned how to take the chest pain as a symptom in the emergency room and take it till you establish the diagnosis. I will take another 5 minutes of your time so that we will also learn about the basic quick emergency room management. The definitive management of the MI is in the hands of a cardiologist, not even a physician like me, but initial stabilization is our role in the emergency room. Whether you are a physician or an intern or a postgraduate student, you are supposed to handle it till cardiologist takes over the case, right? So now let's learn about the basic management of acute coronary syndrome. Management of acute coronary syndrome. So there are two things to learn here: the general management of ACS and definitive management. Definitive management. Okay, so what is definitive management? If I have a case of STEMI, the definitive management is there is a blood vessel which is blocked, you have to open it. We will call it as revascularization. Revascularization, that is opening a blocked blood vessel, which can be achieved by one of the two things. Either you go for angioplasty, which we call as percutaneous coronary intervention. You go into the blocked blood vessel, retrieve the clot, right, and then you dilate the blocked blood vessel, and to make sure that the blood vessel doesn't get narrowed again or get blocked by a clot, you put a stent there. That's your PCI, or you can also call it as percutaneous transluminal coronary angioplasty. That is one way of achieving the revascularization. Or second, you have this fibrin rich clot, right? You can dissolve it by giving the drugs. We will call that as thrombolytics or thrombolysis as a procedure. These are two choices you have. Within that, what do we prefer? Because the results are more promising with PCI or PTCA, this is going to be our preferred treatment. Okay, now the decision making, whether I should, like, okay, if I have the facility for PCI, definitely we will do PCI only. But if I don't have, should I refer for PCI somewhere, or should I do thrombolysis? Well, that's another story that we have covered in the theory part. How do we decide between the thrombolysis versus referral for PCI? For now, it will be it will be an overkill to get into that discussion. I'll keep it aside. We will concentrate more on what general management as we interns need to do in the emergency room. And this general management is not specific for STEMI. Okay, the STEMI definitive management is revascularization, and for NSTEMI patients, we generally go ahead with anticoagulation. Why anticoagulation? Because NSTEMI patients don't have a fully formed fibrin clot, and thus you don't have transmural infarction. So my first step is to prevent this NSTEMI from progressing to STEMI. So by giving anticoagulants, I can stop further deposition of fibrin so that it does not progress to the STEMI. Giving anticoagulation, preferably with heparin, because heparin has a quick onset of action. And then we do go for PCI, but PCI is not as urgent as STEMI, because in STEMI you don't have any other way. You have to remove that block. But here, once you give anticoagulation, the condition doesn't progress further. So you can take a little more time to do PCI. PCI can be done within 24 hours. But in case of the cases of STEMI, PCI should be done preferably within 90 minutes. Within 90 minutes. Okay. Now, if I have unstable angina, for most cases, because you just have the platelet plug here, you don't have much of fibrin deposited here. You have a platelet rich clot, and platelets anyway get dislocated from the site very easily. So I don't have to do much. All I have to do is start anticoagulation, and the platelet plug gets cleared by itself. We will do PCI only if pain doesn't settle with anticoagulants, pain persists or worsens. Otherwise, you don't need to go for the angioplasty for unstable angina patient. But NSTEMI patients will need angioplasty. STEMI patients will need angioplasty. STEMI patients, if you're doing angioplasty, you need to do it within 90 minutes. That's the goal. We call it as door to balloon time. And in case of NSTEMI patients, because you initiate anticoagulation, the further progression of the disease halts. So you can take time up to 24 hours. In unstable patients, as early as is better, but there is a flexibility given to you up to 24 hours. This is definitive management. Its decision is taken by the cardiologist. But what we need to do as intern, the general management that applies to all ACS cases, means we are talking about unstable angina or NSTEMI or STEMI patients. We do the same thing in the emergency room. What is it? Number one, these patients are going through ischemia. There is a myocardial oxygen demand and a supply, and there is a clear mismatch between them. How much the myocardium wants is not being given by the coronaries. And anything that increases the myocardial oxygen demand or decreases the coronary supply worsens the ischemia. The NSTEMI means unstable angina quickly progresses to NSTEMI. NSTEMI quickly progresses to STEMI. If I take those steps which increase myocardial oxygen demand or decrease coronary supply, I have to do opposite of it so that I can slow down the progression from unstable angina to NSTEMI, NSTEMI to STEMI, and from STEMI being small infarct to large infarct. How can I achieve that? Number one, we should put the patient on bed rest, because any physical activity means increased myocardial oxygen demand. Increased myocardial oxygen demand not met by the supply, the disease progresses rapidly. So every patient of anginal chest pain in the emergency room should be put on bed rest. In government hospitals, because of the lack of resources and lack of awareness, I have seen interns sending the patient to take a blood sample and then go to the lab to get the troponins done. At this step of patient moving from the emergency room to the lab to give the blood sample for troponin, that itself can increase the myocardial oxygen demand significantly, and patient may go to the lab and may not come back. On their way, he may collapse because the infarction worsens. So make sure any running around that needs to be done is done by either the ward boys or the patient attenders, but not certainly patients. Bed rest is must. Okay. After the bed rest, next step is continuous ECG monitoring, because we know that the ST elevation may not show up immediately. So I have to go for continuous ECG monitoring. And also patients with the MI are prone for arrhythmias and cardiac arrest. So I need to have a close check on the heart, right? After that, I have to give some emergency drugs in the emergency room itself. And what are the important drugs that I need to administer in the emergency room itself? It's going to be antiplatelets, and if patient is stable, statins. So we give 2 antiplatelets. antiplatelets in the emergency room. That is going to be aspirin and clopidogrel. Selected cases, clopidogrel can be replaced by more potent drugs, but in our emergency rooms, basically we stock aspirin and clopidogrel. And when we are giving dual antiplatelets, we have to give the loading dose of them, aspirin plus clopidogrel. And what is the loading dose? The loading dose of aspirin is 325 milligrams and clopidogrel is 300 milligrams. Many times interns do struggle to gather this 325 milligrams of aspirin because in India we have 75, 150, 300. If I have 75, if I give 4, it becomes 300 milligram. If I have 150, if I give 2, it becomes 300 milligram. So many times we end up giving 300 itself, but ideal dosing is 325. There are only few brands which are available in 325. So pick up that brand and make sure it is stocked adequately in the ICU. Another point you need to remember about aspirin is most of the commercially available aspirin brands are enteric coated. What do you mean by that? Because NSAIDs and aspirin are known to cause gastric irritation, peptic ulcers and gastritis. The manufacturers don't want the patients to suffer through this side effect. So what do? They take aspirin, coat it with some mesh-like substance which slows down the dispersion of the tablet so that the tablet doesn't get released in the stomach. It goes to the duodenum and then it starts releasing the drug there so that the stomach is spared from going through the side effects of aspirin. But now we are in an emergency situation. And if the drug is slowly dispersing, it goes to the duodenum after gastric emptying, which is 2 to 4 hours, and then it starts becoming available for absorption. I don't have that much time, right? I want the aspirin to quickly dissolve and absorb. So what should I do? Commercially available brands, most of them are enteric coated. So if it is enteric coated, you should make sure that patient crushes it or chews it. If enteric coated, patient is supposed to chew it. To be crushed or chewed. Now don't come with the argument saying that, sir, it will be bitter. No, because patient doesn't have much choice. This bitterness versus the life death question, of course you have to go through it. You have to crush and chew it. In India we do have brands which are dispersible and they are sweetened. Like for example, there's a brand called a Disprin, which once you drop in the water it dissolves automatically, so disperses, and it is available in 650 milligram dose. So half of it exactly gives you 325, dissolves in the water quickly. It is sweetened, so you don't have to go through bitterness. You're getting the right dose, and you don't have to think about crushing or chewing it. So I prefer to stock that particular brand in my emergency rooms. Okay. So once you give antiplatelets, not an equally important emergency, but you should, if possible, you should also give statins in the emergency room. What is the preferred statin? You can use atorvastatin 80 milligrams or equivalent dose of it. Like rosuvastatin 40 is equivalent to 80 of atorvastatin. So if you're giving rosuvastatin, you can give 40. Okay. After giving antiplatelets and statins, remember statins is not an emergency situation here. If patient is stable, you give it. Patient is tired, going through severe pain and is refusing to take medication, then just prioritize giving aspirin and clopidogrel. You can skip the statins for now. You can start it later. But aspirin, clopidogrel in the emergency room itself. Okay. After that, you have to take care of the patient's pain. Now, what should I use for pain control? Answer, most of the students give it right. The answer is morphine. Morphine is the drug of choice. The drug of choice for pain control in MI patients is going to be IV morphine. And generally we administer 2 to 4 milligrams of morphine IV. You can keep repeating the doses till the pain settles. Usually at 15 to 30 minute interval, we keep repeating the dose. But the question is, why morphine? In the beginning only, I told you the pain of MI is not often very severe. So when the pain is not very severe, why am I giving morphine? Why not that 325 milligram of aspirin which I gave, which is also painkiller, to take care of it? So why should I give morphine? Well, there is a reason. So whenever we go through pain increases the sympathetic nervous system activity. You go through pain, I go through pain, for whatever reason, sympathetic nervous system activity increases, and increased sympathetic nervous system activity means heart rate increases, because sympathetic nervous system means adrenaline, noradrenaline, dopamine. They hyperstimulate the heart and heart rate increases. Increased heart rate, more the myocardial oxygen demand. Already coronaries are blocked, you are not able to give the demand, and now that heart is asking for more, it suffers through a larger infarct. So pain contributes to the expansion of the size of infarct, and by making sure the pain is controlled well, you reduce the sympathetic nervous system activity and you ensure that the infarct turns out to be smaller. And what if the drug I'm choosing also has a parasympathetic nervous system stimulating properties? Beautifully done, right? So already sympathetic nervous system is overactive because of pain. If I give a painkiller, sympathetic activity comes down, but if the painkiller also increases parasympathetic activity, then heart rate comes down further. Lower the heart rate, lower the myocardial oxygen demand, smaller the final infarct. So that's why, because morphine, in addition to taking care of pain, morphine also increases parasympathetic activity or parasympathetic tone, and by increasing the parasympathetic tone, morphine decreases heart rate, and by decreasing heart rate, it decreases myocardial oxygen demand, and decreasing the myocardial oxygen demand is highly beneficial to a patient going through ischemia. Okay, what else I do in the emergency room? I will also consider administering a beta blocker. It could be any beta blocker. Why beta blocker is used here? Because same thing, beta blockers decrease the sympathetic nervous system activity, right? So by decreasing the sympathetic nervous system activity, beta blockers decrease the heart rate. We all know beta blockers decrease the heart rate, and by decreasing the heart rate, myocardial oxygen demand decreases. What else I can do in the emergency room? So pain control and beta blockers are decreasing the myocardial oxygen demand. How about increasing the coronary supply? How can I increase the coronary supply? Here we have a coronary artery which has a clot. It is partially blocked. That's why blood flow is less. Patient is going through ischemia or infarction. If I give a drug which dilates this coronary, once the coronary dilates, more blood can flow even when you have a clot. Once the cardiologist comes, he will take care of this clot. Either he will dissolve it or he will do an angioplasty. It is left to him. But before he comes, I can dilate the coronary and make more blood to reach the myocardium. So I can increase the coronary supply. And how can I dilate the coronaries? Yeah, beta blockers also help you, but potent vasodilators are nitrates. And because I want it to act immediately now, I will use it in sublingual form. So we also give sublingual nitrates in the emergency room. The sublingual nitrates will cause coronary vasodilatation and they will increase coronary flow. So my last question is, what about oxygen in the emergency room? Should I give oxygen to a patient going through acute coronary syndrome? Because many of the students learn this mnemonic from pharmac books and pharmac video lectures on the YouTube, that there is a mnemonic to remember what needs to be given in the emergency room to a patient with MI, and that is MONA. MONA stands for morphine, oxygen, nitrates, and antiplatelets, that is aspirin and clopidogrel. But please remember, merely using oxygen does not improve the chance of myocardial cell survival, because myocardial cell survival needs ATPs. These ATPs are formed from glucose or free fatty acids, and to convert glucose to ATPs, I need to use oxygen. But if you only give me oxygen, but you're not increasing the supply of glucose and all the enzymes and substrates required for the oxidative phosphorylation, mitochondrial electron transport chain, Krebs cycle, then I can't make ATPs. Merely oxygen is just waste. And that mere oxygen that you're giving can be a free radical, can get converted as a free radical and cause more injury to the heart. So oxygen should not be given just like that randomly for all patients of chest pain or acute coronary syndrome. You will give oxygen only if patient is hypoxic. No hypoxia, no role of oxygen in the management of MI, right? So I will just make a note here that O2 only if hypoxia. Only if hypoxia. Routine use of oxygen is not recommended. This way, you have handled the case who came with chest pain efficiently in the emergency room, from taking the symptom to diagnosis and doing the initial stabilization and management. You have given them antiplatelets, you have given them a pain control measure, you have given them beta blockers and nitrates, and if patient was hypoxic, you have also started them on oxygen. And after that, the physician or cardiologist arrives and then takes a decision about definitive management. If you want to know more about the definitive management, you can go through the app lectures on the acute coronary syndrome. The theory part is discussed there. So today I conclude my session. Today we have discussed the chest pain. Similarly, we will take up other important symptoms. We will take it from the symptoms till the diagnosis and initial management. Okay, so that's it from me today. The okay. Okay, so I think someone was quite confused about what are we discussing. So we are discussing about the emergency room diagnosis of patient presenting with chest pain into acute coronary syndrome and how we do initial management. Okay, now I have a small tip for some of you who are very seriously interested in preparing the case presentations, right? How to take history, how to approach further. Okay, so of course we will be doing the pocket clinics, but today is the era of AI. So can I use AI to better my history taking, better my approach to emergency room cases? Yes. So one suggestion I have is you can take Gemini. Okay, so like you have this app called Gemini, and what you can do in the Gemini is you can ask the Gemini to act as a patient. So the prompts I can definitely share you in the PDF itself, where I'll give you the prompts. Like one of the prompt may be, hey Gemini, act as a patient presenting with the emergency room with this particular complaint, or you can say OPD. You can choose the setting, emergency room or OPD. If it is a OPD case, you can choose OPD. If emergency room, you can choose emergency room, and you just tell the complaint, and then tell the Gemini that you can think of any possible diagnosis for that particular symptom. So act as a patient presenting with chest pain in the emergency room. You may be any case of acute chest pain ranging from the acute coronary syndromes to the esophageal perforation to the dissection of aorta. And then I will be asking you the questions related to your complaints and history. Keep giving me the answers accordingly. So literally you have created a virtual patient in front of you. You can do this voice exchange itself, right? Like you can see this voice here. Let's see if I can get it done from the Gemini right now. Hey Gemini, I want you to do a role play. I want you to act as a patient coming to the emergency room with chest pain as a complaint. You can think of yourself going through any of the possible diagnosis for that chest pain. It could be an acute coronary syndrome or a ruptured esophagus, or it could be costochondritis, GERD, any of the possibility. You play the role of that patient. I will play the role of a doctor. I will ask you the questions. I want you to give me the appropriate answers from the history that you have presumed the role of. And once I give the command, the Gemini gets ready. Gemini gets ready with the
shut. Ambient beep of a cardiac monitor echoes in the background.
Okay, guys, I hope I'm audible now. So there were some audio issues. So what I was telling you is, if I give the story to a Gemini, Gemini comes out, it starts playing the role, and then you can literally talk to the Gemini like you're talking to a patient. You can ask all the leading questions that you need to ask, like what was the nature of the pain, where is it getting radiated to. It will give you all the answers. So you can, in your mind, make up a pattern, whether it is looking like anginal pain or acute pericarditis pain or esophageal perforation pain. And after that, you can also ask the Gemini to give you the examination findings. So it will also tell you what examination findings you can see in me as a role play that I'm doing. And after that, you can again narrow down the differential diagnosis in your mind. And then you can also ask the Gemini to give the investigation reports. So it might give you an ECG with ST elevation, or it might give you a troponin elevation according to what role it is playing. So this way you can practice the history taking, analyzing the reports, and analyzing the examination findings. And by the time you become intern, you will be fluent in dealing with patients. Today is the era of AI. You don't have to literally have a patient of chest pain to learn how do I talk to a patient with chest pain and arrive at the diagnosis. So start using some AI tool like Gemini to practice taking the history, and this will help you in good case presentation. So that's it from me today. The notes will be shared with the team, and the team will make it available through a Google form. Under the video, in the pinned comment or the description of the video, you will get a link for the Google form, and that link will help you to download the note. That's it from me here today. I'll see you